So Marfan syndrome is a relatively common genetic disorder, and it is very commonly tested on the USMLE, as you probably have gathered, based on the practice questions you've done. And it's also very commonly tested on step 1, so you should have some level of familiarity with this. So this is an autosomal dominant disorder, and it affects the extracellular matrix, particularly the component called fibrillin. And this is actually a genetic mutation of the gene that codes for fibrillin. And it is associated with a tall stature, as well as skeletal, cardiovascular, and ocular manifestations, and it affects approximately 1 in 5 to 10,000 live births. So it's a mutation of fibrillin 1, which is found on the long arm of chromosome 15, codes for fibrillin 1, and fibrillin 1 plays two major roles. One, it's a component of the extracellular matrix, so it's important in connective tissue. It also plays a cytokine regulatory role, sharing homology with TGF-beta binding protein. And TGF-beta binding protein is responsible for sequestering TGF-beta. So if you have less fibrillin 1, you're going to have more activity of TGF-beta. And that's what we think plays the bulk of the role in the pathophysiology of Marfan syndrome. So if you have more TGF-beta activity, it's going to stimulate the production of collagen, tenacin, periostin, fibronectin, and so forth. However, you don't have sufficient fibrillin 1, and so the connective tissue is going to be abnormal. And this probably explains the cause of abundant elastic fibers in the aorta and ligaments, but the complete pathophysiology of Marfan's is still not completely understood. As far as inheritance, 70% of Marfan's cases are familial, autosomal dominant, so mom or dad has it, 50-50 chance the child gets it. But 30% are sporadic, and those sporadic cases are associated with increasing paternal age. So remember that the trisomies, the Down syndrome, and Patau syndrome and Edwards syndrome, those are associated with increasing maternal age. Marfan syndrome is associated with increasing paternal age. There are a lot of features of Marfan syndrome. The ones I put in red here are probably going to be the ones that come up on the test when they give you a vignette. So there are craniofacial features, dolichocephaly, and so dolichocephaly is a long, and we're talking long in the anterior-posterior direction, a long, narrow skull. They can have recession of the eyeball in the socket, and this is usually pretty discrete, but this is called enophthalmos, which is the opposite of exophthalmos, which you see with hyperthyroidism, particularly Graves' disease. An anti-mongoloid slant, malar hypoplasia, and retrognathia or micrognathia. Usually these craniofacial features, though, are pretty subtle. Skeletal features are probably going to be the most obvious. So Marfan syndrome is characteristically a tall, lanky patient with long arms and long legs, disproportionate overgrowth of the long bones, so humerus and femur. The arm span is usually longer than the height by about just a little more than 100%, so 1.05 times the height. The lower segment is typically much bigger than the upper segment, so it's a reduced upper segment to lower segment ratio, and I'm not exactly sure, I don't really remember what the exact ratio is. I think it's like 0.85 or 0.86 or something like that. But it is there is a reduced upper to lower segment ratio. Pectus deformity is commonly seen, particularly pectus excavatum, but you can also see the pigeon chest as well, pectus carinatum. Arachnodactyly is a very common feature in most Marfan syndrome patients. Kyphoscoliosis can be seen, as well as thoracolumbar scoliosis. You can also see an inward protrusion of the acetabulum. Typically, though, this is asymptomatic, so you'll need to get a radiograph to see this. Pes planus is a common feature of Marfan syndrome. That's the flat foot. But they can also have an arched foot, and they can also have deformities of the hind foot, and they can have club foot as well. And then joint laxity is a feature of Marfan syndrome. It's also a feature of Ehlers-Danlos syndrome, and so this is going to be an important differential. Most of these skeletal features we tend to not see so much in Ehlers-Danlos syndrome, and then also Ehlers-Danlos syndrome has that skin hyperelasticity that we don't see so much in Marfan syndrome. We don't see at all, really. The cardiovascular features are also important to keep in mind because this plays a role in the morbidity of patients with Marfan's. So you can have thickening of the AV valves. Typically this manifests as mitral valve prolapse. Usually mitral valve prolapse is something that you only will be able to hear. Doesn't lead to symptoms, but in some cases it can lead to symptoms, and that would be regurgitation, mitral regurgitation, as well as in extreme cases it can lead to congestive heart failure. And in children, the congestive heart failure secondary to mitral valve prolapse is the #1 cause of pulmonary edema, pulmonary hypertension, and early death in children, young children. They can develop an aortic root aneurysm, which can be really, really problematic, and this is something that we're going to be monitoring for in these patients, making sure it doesn't get too big, in which case we're going to perform surgery. Acute aortic dissection can be a cause of sudden death in these patients. Dysrhythmias can come up. Usually it's going to be just a prolongation of the cardiac cycle in general. That can be they can have a prolonged QT interval. They can also go into atrial fibrillation and SVT. Some of these patients will also have an atrial septal defect, which is usually, again, asymptomatic. A common feature of Marfan syndrome is the displacement of the lens. This is going to be an upward displacement of the lens. We call this ectopia lentis. It's typically upward. If there's a downward displacement of the lens, that's usually seen in homocystinuria. So upward ectopia lentis. These patients also tend to have a longer eyeball, which causes them to have myopia. They can have a hypoplastic iris, ciliary muscle hypoplasia, which can make accommodation difficult. They also have an increased risk of cataracts, retinal detachment, and glaucoma. A common feature that you see in Marfan syndrome, and probably due primarily to their height, is an increased risk of spontaneous pneumothorax. So in tall patients in general, young tall patients, they have a risk of spontaneous pneumothorax. That risk is about 15% in Marfan syndrome. Dural ectasia is just a ballooning of the dural area, and this can cause lower back pain, but it can also cause neuropathy. It can cause incontinence. It can cause pain. And then stretch marks can be seen, as well as inguinal hernia. So no patient is going to have all of these, and even these ones in the red, no patient is going to have all of these, but these are the ones that you should remember, at least these ones in the red. A mnemonic for Marfan syndrome can be remembered by just remembering the letters in the word Marfan's. So mitral valve prolapse, aortic aneurysm, retinal detachment. F means flexible or joint laxity, as well as the fibrillin 1 mutation. Arachnodactyly, negative nitroprusside test, not a common test to be done, but this can be done to differentiate it from homocystinuria. And then subluxation of the lens and scoliosis. So this is an example of the wrist sign, which is seen in clinical practice. If you're looking for Marfan syndrome, and this is just a function of arachnodactyly. So when this patient wraps their hand around their wrist, the pinky crosses the thumb. And if you were to do this on yourself, actually not only does the pinky cross the thumb, it looks, I'm not sure. Ring finger, yeah, the ring finger should cross the thumb a little bit, but the pinky shouldn't cross the thumb at all. So if you try this on yourself, you'll see that this is quite long. And this just has to do, to a certain degree, with joint laxity, but more so with the arachnodactyly. So you can see that this patient has really long fingers. We can call those piano fingers. This is the thumb sign. So when you close your fingers with your thumb flat against your hand, the thumb should not go past the ulnar side of the forearm. This is the classic Marfanoid habitus, the long legs, long arms, and the arm span is going to be In many cases, it's going to be taller than the height, but that can vary. Again, here you see the lanky patient, lanky, tall patient. So long legs, long arms. You also see the pectus deformity here. And these patients also tend to be very thin too, but not all of them. This is a very obvious case of Marfan syndrome. So this, when you're doing the upper to lower segment ratio, you're not going to be asked this on the test, but you can use a nomogram, and the nomogram gives you what the normal or mean upper to lower segment ratio is for a population given the age. And I believe this is going to be, here they have it separated by race, but I think you may have to separate this by sex too, I'm not sure. But here you see the mean and then the standard deviations from the mean. So here's the obvious Arachnodactyly. And then this is pes planus, so very flat feet. Also you can see Arachnodactyly in the toes as well. Now, it's not as common to see Arachnodactyly down there. Usually it's more pronounced in the fingers, like in this patient. Here's an example of joint laxity. So this is a feature that you'll see in common with Ehlers-Danlos syndrome, particularly the hypermobile type. And then this is a dislocation of the lens. You can see this is an upward dislocation, so it looks like the sun is going up, and that's where the lens is. So here's your upward dislocation of the lens. This is Protrusio acetabuli, or protrusion of the acetabulum. So here's a normal hip radiograph. You can see that there's space in between the head of the femur and the acetabulum. Here you can see that that space is obliterated because of protrusion of the hip. Then this is dural ectasia seen on MRI. And this is usually subclinical, but it can cause back pain and also lower leg pain and incontinence in some cases if it impinges on a nerve. And you'll also see dural ectasia in neurofibromatosis. You can see it in Ehlers-Danlos syndrome rarely. You can also see it in some other syndromes too. This is an ascending aortic aneurysm. Chest x-ray is not the best way to diagnose this, but in some cases this may be how you see it. So here is an MRI. So this is an aortic root aneurysm right here. And this is this on the left here is a 3D CT. And this is the same patient here. This is an aortic dissection, so just note this intimal flap here. And this is a dissecting region here, and this is the true lumen. There's the flap. Sorry, it's right here. Okay. All right, so development. Most patients with Marfan syndrome early on will have hypotonia, and this may or may not be diagnosed or noticed. Hypotonia can always lead to, if it's early, can always lead to delay in gross motor milestones. But otherwise, these children will track tall for their expected height, and many children will discover that they are double jointed. Cognitively, because they can have really severe myopia in some cases, if that's not diagnosed, that can lead to difficulty in school. But otherwise, Marfan's is not going to cause any difficulty in the cognitive or social domains. So this is a clinical diagnosis. Genetic testing is only going to play a secondary role. The initial workup is going to include a comprehensive history and physical examination, a cardiovascular workup, which includes an EKG and echocardiogram, radiographs of the hand, spine, pelvis, chest, foot, and skull, You can do an MRI to look for dural ectasia. Like I said, this is usually an asymptomatic process. And then a referral to ophthalmology for a slit lamp examination. So you'll start with your comprehensive history and physical examination. And what you're looking for here is a systemic score. Don't memorize this, but just know that these are the symptoms of Marfan syndrome. These are your findings that you'll see on physical exam. So the wrist sign and the thumb sign together, that's 3 points. And we're looking for the magic number here is 7. So the wrist sign and thumb sign right there puts you at 3 points. If you have either the wrist sign or the thumb sign, that's going to be 1 point. A pectus carinatum is 2 points. Pectus excavatum is 1 point. Chest asymmetry is 1 point. A hindfoot deformity is 2 points. Pes planus is 1 point. A history of pneumothorax is, and that's going to be a spontaneous pneumothorax, not due to trauma or anything like that. That's 2 points. Dural ectasia is 2 points. Protrusio acetabuli is 2 points. Arm span to height ratio more than 1.05 or decreased upper segment to lower segment ratio is 1 point. Hyposcoliosis or thoracolumbar scoliosis is 1 point. The characteristic facial features, including the dolichocephaly and ophthalmos microretrognathia, is 1 point. Striae is 1 point. Myopia is 1 point. And mitral valve prolapse is 1 point. So you can see why maybe you'd want to get the radiographs, because if the patient is at 5 or 6, then perhaps you may see the dolichocephaly, or you may see very obvious signs of pes planus, or maybe subtle signs of scoliosis, or the protrusio acetabuli if you look at the hips. And then that can put you above where you need to be as far as having a score of 7 or more. So the Ghent criteria is used for making a formal clinical diagnosis of Marfan syndrome. Now, if you have a patient who has a family history of Marfan syndrome, that's going to make the diagnosis a lot easier. So if there is a family history of Marfan syndrome, then all you need is a systemic score of more than 7. If the systemic score is more than 7, then in a patient with a family history of Marfan's, and usually they do, 70% are inherited, then you have a diagnosis right there. Also, if you have a family history of Marfan syndrome and the patient has a dislocation of the lens, that's a diagnosis. And then if they have a family history of Marfan syndrome and then they have aortic root dilatation, that's also going to be a diagnosis of Marfan syndrome. And the definition for aortic root dilatation, when we're talking about a patient with a family history of Marfan syndrome, we have to use a little bit stricter criteria than we would otherwise use. So if the patient's younger than 20, they have to be they have to have a Z-score of more than 3. And if they're 20 or older, then we use a Z-score of more than 2. Now, if they don't have a family history, then we need to prove a few more factors, because we don't have that predisposing factor of family history. So what we're mostly looking for is, if they don't have a family history, we're looking for aortic root dilatation. And the cutoff is a Z-score of 2. So if it's more than 2, then that's considered a positive sign for Marfan syndrome. So aortic root dilatation plus ectopia lentis is Marfan syndrome. Aortic root dilatation plus a systemic score of more than 7 is Marfan syndrome. And then aortic root dilatation plus any kind of fibrillin 1 mutation is Marfan syndrome. So this is really where the genetic testing will come into play. If a patient has aortic root dilatation, but you really don't see anything else, but that aortic root dilatation is significant, you want to know if they have Marfan syndrome, because if they just have aortic root dilatation, but they don't have Marfan syndrome, that may give a different prognosis on the aortic root dilatation than if they did have Marfan syndrome. Because in Marfan syndrome, the aortic root dilatation tends to be progressive, and so that requires much more significant monitoring. So if a patient has no family history, they have this aortic root dilatation, in that case, that might be a good time to get a genetic testing. And then ectopia lentis plus a fibrillin 1 mutation that's known to cause aortic disease, that can be Marfan. That's Marfan syndrome as well. So again, On the USMLE, you're not going to be asked the Ghent criteria, but you will be given a scenario that displays these things. So you should know what the general features of Marfan syndrome are, that aortic root dilatation is a big deal, and that having a family history is significant. The diagnosis can be made clinically, provided that you don't have any discriminating features of an alternative diagnosis, such as Ehlers-Danlos syndrome or Loeys-Dietz syndrome, or some of these other syndromes that we're going to talk about on the differential. So the differential includes a mass phenotype. So a mass phenotype is where you have mitral valve prolapse, an increased aortic root diameter, striae, and skeletal features consistent with Marfan's. So this would be a case where really the distinguishing factor is going to be the growth in the aortic root diameter. So in mass phenotype, they typically don't have a progressively increasing aortic root diameter. So in this case, they tend to have an increased aortic root diameter, but they're at a lesser likelihood. They still have a greater than normal likelihood, but they're at a slightly lesser likelihood than with Marfan syndrome to wind up having an aortic dissection. So this is something you should consider in patients without a family history of Marfan syndrome, as well as in patients with an increased aortic diameter, but not a Z-score of more than 2. And these patients should be followed up carefully with echocardiogram to ensure proper diagnosis. So determining the difference between Marfan syndrome and mass phenotype can be very difficult, and so for that reason, we follow these patients up carefully. Ehlers-Danlos syndrome shares a lot of things in common with Marfan syndrome. So the joint hypermobility, aortic complications, ectopia lentis, other ocular complications. But in Ehlers-Danlos syndrome, there will be other signs that typically aren't seen in Marfan syndrome, like stretchy skin, easy bruising, blue sclera, droopy ears, poor wound healing. And there can also be GI symptoms as well, and chronic pain. To diagnose Ehlers-Danlos syndrome, you don't necessarily need to get genetic testing. We don't always do that to diagnose Ehlers-Danlos syndrome itself, but there are some particular genes that are associated with Ehlers-Danlos syndrome that are never associated with Marfan syndrome. One would be COL3A1, which is associated with the vascular Ehlers-Danlos syndrome. There's other genes, collagen-related genes that can be tested as well. But Ehlers-Danlos syndrome has its own clinical criteria for clinical diagnosis called the Brighton criteria that are used to diagnose EDS. Loeys-Dietz syndrome is very similar to Marfan syndrome in that it shares the cardiovascular and skeletal features of Marfan syndrome. However, Loeys-Dietz syndrome does not cause ectopia lentis, but not all patients with Marfan syndrome will have ectopia lentis, so that doesn't do us very much good. What you do see in patients with Loeys-Dietz syndrome is this abnormal facies, which includes hypertelorism. They tend to have a broad or bifid uvula. They can also have easy bruising, arterial tortuosity, cardiac defects, the Arno-Chiari malformation, Talipes equinovarus, or learning disability. And you can get genetic testing for Loeys-Dietz syndrome, and this is the TGF receptor gene, so TGF-BR1 or TGF-BR2. You can see how this is similar to Marfan syndrome as far as pathophysiology, because remember that Marfan syndrome is a deficiency of fibrillin, which sequesters TGF, and so that causes increased TGF activity. Whereas Loeys-Dietz syndrome is an activating mutation of the TGF receptor, and that causes increased TGF activity, quote unquote. Important differential here from Marfan syndrome, because with Loeys-Dietz syndrome, even though it's not the same as Marfan syndrome, you do have aortic root aneurysms, and with Loeys-Dietz syndrome, the aortic root aneurysms tend to happen at smaller dimensions, and I should say aortic root or aortic dissections tend to happen at smaller dimensions. but the aortic root aneurysms tend to happen at younger ages too. So this is a little bit more problematic in this syndrome compared to Marfan syndrome. It's problematic in both, but with Loeys-Dietz syndrome, it tends to happen younger and earlier. Sprintzen-Goldberg syndrome is very similar to Loeys-Dietz syndrome, pretty much except for the fact that you don't have the aortic root aneurysms. And then homocystinuria shares with Marfan syndrome. It's tall stature, long bone overgrowth, ectopia lentis. However, in homocystinuria, that lens dislocation tends to be downward, whereas in Marfan syndrome, it tends to be upward. It is not associated with aortic dilatation, and patients with homocystinuria tend to have intellectual disability. They also have an increased risk of thromboembolism and coronary artery disease. For diagnosis, you can get a plasma homocysteine, and that's going to be elevated. The long-term management for Marfan syndrome is preventative and surveillant. So you get annual evaluations by cardiology, including an echocardiogram to make sure that the aortic root is normal or that the progression is stable. Beta blockers are traditionally used to reduce the risk of aortic dissection. Annual evaluations should be done by ophthalmology, particularly looking for lens dislocation. These patients should be monitored clinically for scoliosis, and then, of course, with any genetic disease, they should be referred to a genetic counselor. Life-threatening complications include aortic aneurysm. So this would be a case where you would get surgical repair, typically recommended at more than 5 centimeters or at a growth of more than 1 centimeter per year of rate. So either of these would be indications for surgery. However, it can be performed sooner if there's a family history of aortic dissection or aneurysm rupture. It can also be done if there's severe aortic regurgitation leading to congestive heart failure. So it's pretty similar recommendations to what we would do with anybody with an aortic aneurysm. And then acute aortic dissection, this is typically something that is seen in the ER. And the symptoms would be tearing pain in the region of dissection, which is invariably going to involve the aortic root, since that's the area that's most affected in Marfan syndrome. You can also get neurovascular insufficiency due to reduced blood flow to the carotid arteries. Rapid onset congestive heart failure due to regurgitation. If this cuts off the cardiac arteries, this is going to lead to an MI, and that can lead to sudden death. So this affects the coronary arteries. So remember that those coronary arteries are the very, 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 very first arteries that come off right off of the aortic root. So if that's affected, that's going to cause an MI. And obviously the treatment for this is emergent surgical repair. Long-term considerations, so really important that they get their regular follow-up and monitoring to minimize the risk of potentially lethal cardiovascular complications. As far as when the patient asks you, which they always will, eventually, what their risk is of transmitting this on to their offspring, if they have Marfan syndrome that was familial, then they have a 50% chance of transmission. And remember that 70% of Marfan's cases are familial. So either they have an affected parent or they have affected family members. If they have a sporadic Marfan syndrome, that tends to have a lower transmission rate. So I'm not exactly sure what the numbers are, but it's lower than 50%.